Welcome to the 15th in our series of podcasts. In this latest edition of the Encephalitis Podcast, I am delighted to be joined by Professor Jon Stone, who is Consultant Neurologist and Professor of Neurology in Edinburgh, and Dr. Tim Nicholson, who is a Neuropsychiatrist at the Institute of Psychiatry, Psychology and Neuroscience, King's College, London. So we are in great hands for this conversation, which is going to be on functional neurological disorder, or FND, as it's sometimes referred to. Welcome to both of you to the Encephalitis Podcast.
Thanks very much, Ava.
Yeah, thanks for inviting me.
You're so welcome. Well, look, I think, we're going to start at the beginning, and Tim, I'm going to ask you first to just tell us briefly, what is functional neurological disorder?
Thanks, Ava. So it's actually a surprisingly complicated question because it's a particularly complicated disorder at the interface of neurology and psychiatry, and therefore really body and mind. And our models and understanding of this disorder have evolved a lot over hundreds of years and are still evolving as we speak. So it goes by a lot of names, and it's previously gone by the name of hysteria and conversion disorder, which has a more sort of Freudian sort of connotations, but it's now known as FND, or functional neurological disorder, because we're sort of more aware that it's a complex brain disorder at the interface of neurology and psychiatry. But in simple senses, it's really a real and common cause of often severe neurological symptoms that can often get misdiagnosed and missed, but it can be very severe and highly impairing, which can be distinguishable from other causes. So it's relatively easy and robust to do that with if you've got sufficient expertise. I think that's just a brief overview of what it is.
And Tim, how do patients present with FND? Are there any common presentations?
Yes, it sort of can and does mimic almost any combination of neurological symptoms, but the most common symptoms would be seizures, weakness of muscles, which could be leg, arm, or face, but also movement disorders, so tremors, jerking movement, spasms are common, as are sensory changes from loss to paresthesia, so pins and needles, to pain syndromes, but also increasingly recognised as cognitive or memory problems, which some classification systems see as separately, but we all commonly see alongside the other symptoms I've mentioned, but also can be discrete on their own and very, again, quite common and highly impairing cause of cognitive or memory problems.
Well, thanks for that. Jon, I'll turn to you. A lot of the symptoms that we've just heard about seem to me to be similar to those seen in some other neurological diseases, such as multiple sclerosis, encephalitis, of course, Parkinson's, epilepsy. Is this a challenge for doctors when it comes to diagnosing functional neurological disorder? And indeed, how is it diagnosed?
Yes, so that's a good question. I mean, in fact, if you think about it, there aren't that many neurological symptoms. You can have a weak leg, you can have confusion, tremor. The list isn't that long, and yet there are hundreds of different neurological conditions. So one of the common errors in thinking here is that people, some people think that FND is a condition you diagnose when someone has neurological symptoms, but you can't find a brain disease to go along with it. And that's absolutely not the case. Some people do that. If they're doing it like that, then they're doing it wrong. So we make this diagnosis based on, in the same way that we do for MS and Parkinson's, on typical clinical features, things that only happen in FND, but don't happen in other conditions. So we have clinical signs such as Hoover's sign of leg weakness, or the tremor entrainment test, or typical clinical features of a functional seizure, or FND seizure. These are things that we know are repeatable and robust, and mark out a group of patients and symptoms that have the potential to be treated by FND related treatments. So yes, it is difficult sometimes to tell the difference, and particularly because there are patients who will come to who have both FND and another neurological condition. And that's why we do need practitioners who are very experienced in neurology and learn to tell the difference. So yes, it's a really good question. It's not just about symptoms and not finding a disease. That's the old way and really needs to be erased, I think.
Well, functional neurological disorder is something that seems to cross paths with encephalitis. Of course, that's why we're doing this podcast. And it's something that certainly poses a challenge for our support team at the Encephalitis Society, who, of course, always want to give the right advice. And they've described for me kind of three scenarios, and I'd like to put them to you, Jon, for your comment. So first of all, for example, we have people who approach us who've been diagnosed with encephalitis, but who turn out to have functional neurological disorder. Why do you think that is?
Yeah, so well, we see, as I'm sure we'll come to, we see misdiagnosis in both directions. So, of course, nobody wants to have a misdiagnosis. It's very distressing for patients and the doctor who's made it. But I think there's a number of reasons why people, and I think it's probably more common actually that people with FND end up being misdiagnosed with another neurological condition. It's sometimes that people have done that they're not looking for these positive features of the condition, so that if they look at the person in front of them and examine them and think about their symptoms and how they are changing over time or changing different examination tests, they might raise the possibility of FND a bit earlier, rather than seeing it as a diagnosis of exclusion, which many people do. The other issue that comes along is that people end up doing tests which raise the possibility of encephalitis without thinking about how sensitive and specific are these tests. So if you have a very low titer of an antibody, for example, some of the the VJ-KC antibodies, etc., can be false positive sometimes. So you end up making a diagnosis wrongly for that reason. Or you might see something on a brain scan that hints at encephalitis, but turns out to be a benign or common change in the population or an artifact of the scan or something like that. So many reasons. And then finally, I think there's a kind of bias amongst patients and doctors that when you're ill and you've got disabling symptoms, you want to hear that you've got a condition that other people have heard of that is unequivocally not your fault, etc. I mean, FND is not anyone's fault either, and that's one of the things we need to change. But there's a bias that heads in that direction, I think.
Yes, and I think you alluded to this in what you were just talking about. So our second scenario is patients who come to us who are recovering from autoimmune encephalitis, but who were initially misdiagnosed as FND. This could seem strange to many listeners who are familiar with autoimmune encephalitis, as some of the symptoms that we've talked about, seizures, sensory issues, for example, they seem to be a perfect fit for FND, as you know, for want of a better word. That's our second scenario. Is that something you're familiar with?
Well, there's a couple of things going on here. So I think there are patients who present with unusual types of neurological symptom, for example, facial-brachial dystonic seizures and LGI1, where the EEG might be normal, for example, and someone might say, oh, the EEG is normal, you've got FND. Now, that's a good example of how you shouldn't diagnose FND through normal tests. But you should look at the symptoms in front of you and think, well, could this be LGI1? I think if people do that properly, that these errors are much less likely to occur. Quite a lot of the published misdiagnoses cases where someone said, oh, we called it FND and it turned out to be encephalitis, are like that actually. When you look at them, there was never any clear evidence of FND. But the other scenario is that there are patients who definitely do have FND, and I've seen these patients too. I've seen a patient have a functional seizure in the sort of prodrome of their NMDA encephalitis. Now, it was functional seizure. They also had anxiety. They also had panic. So you can have FND or psychiatric problems as part of encephalitis. The two are not mutually exclusive. And so it's not always a misdiagnosis. It's just that it's an incomplete diagnosis. And the person at that point perhaps should have been thinking, well, why has this person developed FND now? Can I put together all of the different things that are going on? Is this really typical FND, or could this person also be developing another neurological condition?
And just for clarity for our listeners, Jon, you mentioned a functional seizure there. Just how does that differ? What do we mean by a functional seizure?
Well, what we're looking for in an functional seizure or FND seizure is it's that there's a number of things that happen. For example, at least a third of the patients will have an episode where they become suddenly motionless and unresponsive and lie with their eyes closed for several minutes. Now, there isn't another condition in neurology or psychiatry that presents like that. That's just a sort of fact of clinical observation. If someone's having an episode where they're shaking all over, you're looking for quite a long episode usually. So epileptic seizures very rarely last longer than 90 seconds, whereas functional seizures will often last for many, many minutes. The eyes will often be closed rather than open. Patient might be breathing fast instead of stopping breathing. And there are other things too. So each of these on their own isn't necessarily that reliable, but you put them together. So this is clinical neurology. And so you do want to have those things. A functional seizure, if it's like anything, it's a bit like a cousin of a panic attack in terms of what's going on in the brain. It's a red alert state, and then the brain sort of shutting down to get rid of that red alert state. That's the kind of pathophysiology of it. But it just happens to look like an epileptic seizure at times.
That's really helpful, thank you. And our third and final scenario that we see at the Encephalitis Society, Jon, is there are people who are recovering from encephalitis, infectious or autoimmune, who then go on to develop functional neurological disorder. Is FND something that can emerge later as a result of encephalitis?
Absolutely. So one of the strongest risk factors for FND generally, and this is something I think that was appreciated 100 years ago and sort of got rather forgotten, is the presence of another neurological condition. So, for example, about 20% of people with FND seizures have epilepsy. Now, if you look at those patients, they've nearly always had epilepsy first. So they've had experience of having epilepsy. It's terrifying. You don't know when you're going to have a seizure. That process of experiencing epilepsy creates a vulnerability and risk of developing FND. So it's not a case of either or. We very often see patients who have a condition like encephalitis, or they've had it and they've got FND, and the two things are there together. And the reason it's important to distinguish them is that I think they have different treatments. And if someone's still having seizures and it turns out to be FND seizures, well, you want different treatments than if it's epilepsy. So I think we need a sort of medical climate where we just regard FND as any other type of diagnosis, which we can put on the list as possible causes, and which has a particular treatment attached to it.
Absolutely. Tim, I'm going to turn to you. What would your advice be to someone who thinks that they've got FND? Is there a pathway that people can follow, and what type of professionals deal with FND? Who should they be being treated, diagnosed, or assessed by?
Thanks, and yes, it's an interesting question, because I think, as Jon hinted at, there's quite varied knowledge and expertise around FND, and I think huge strides have been made in the last decade or so of raising awareness and increasing clinical skills, but it's still largely a specialist diagnosis that, particularly for sort of more complex ones, or when there's disentangling two potential disorders. So I think a neurologist is generally the key person for that, and sometimes that needs to be someone with a particular expertise in seizures or movement disorders to unpick the clinical phenotypes. But the majority, a sort of general neurologist, will be able to pick apart on a good general physician who's got experience of this. So that's been the shift, that it used to be thought it was much more of a psychiatric disorder where psychiatrists would need to find trauma or stress, and that's very much been the sort of shift, that's not what's needed for the diagnosis. Is these positive signs that distinguish it from other disorders, as Jon mentioned. So the neurologists are really key. There is a sort of subspecialty of psychiatry called neuropsychiatry, who many encephalitis patients might sometimes see as well, but those professionals sort of specialize in this area as well, at that interface of neurology and psychiatry. So sometimes they might have the skills to disentangle this sort of case, but I think that's really in the realm of specialists. But I think our sort of mission and sort of dream is that this can, because it's such a common important disorder, is that this could be something that's part of the core curriculum, and because it's so common that people can start to unpick this. So for example, patients could present with a stroke-like presentation, and that's really important to sort of pick out in A&E. So emergency department workers need to be able to unpick this, and same for people presenting with acute seizures, because these are very common sort of differential diagnoses of other disorders such as epilepsy or stroke acutely. So but I think the other key professionals to involve are physiotherapists and occupational therapists and psychologists. So we all play a part in a sort of multidisciplinary approach to this disorder, and a lot of these other professionals are very good at, because they see the distinct phenotypes of the functional FND versus the other types of presentations, and they can have a lot of sort of great clinical awareness of the differences, and can help with the diagnostic process as well. So that can be, there's sort of other key professionals to involve.
Thanks, Tim. It interested me there that you talked and mentioned it a couple of times about how common FND is, and that just got me thinking. I mean, how common is it in comparison to some of the other conditions that we've been talking about?
Well, you could argue it's one of the most common diagnoses, and Jon and his colleague Alan Carson and others in Edinburgh have really led the way at sort of doing very large studies in Scotland, and Jon could talk about it a bit more, which has been replicated in Australia more recently, that it's really anything between 10 and 30% of neurology outpatients, so depending on how you define the disorder, or whether it's on its own or in combination or part of the problem. So I think it's second only really to headache in terms of being the most common type of presentation. And similarly, in all settings across medicine, you see FND as a very common disorder. So it's something that's a sort of hidden sort of massive problem, really. So it's not a niche diagnosis by any means. It should be a core medical problem that has a lot of funding and understanding and education. But unfortunately, although we're making strides in that direction, we're still a long way from reaching that.
Wow. Okay. Well, I've learned something today. That surprises me. But Jon, I'll turn to you. Tim just touched upon this, but I understand that there are some randomized control trials of therapies associated with FND. What can you tell me about any successful or new treatments for the condition?
Yeah, well, so in the last couple of years, particularly in the UK, there have been some larger randomized control trials. We're still, I think it's fair to say, at an early stage here of developing our treatments, because the field was so stagnant and nothing was happening. So it's really only the last 10 or 15 years. We have, for example, a large randomized trial of physiotherapy for functional motor disorders going on in the UK at the moment, which was run by Nicholson from St George's, and that was based on an earlier pilot trial that Glenn did of 60 patients with really impressive outcomes, actually, for patients with functional motor problems like paralysis and movement disorder. And he developed a treatment based on this very transparent understanding of FND as a condition that varies depending whether you're trying to think about the problem or not, and sharing that with patients and doing quite intensive treatment. So that trial, for example, 30 patients who had this intensive physio, 70% had a good outcome in 6 months, compared to 20% of patients who had the same amount of physio, but just not directed specifically at FND. It was the kind of treatment you might have for stroke. So there's a feeling there that specific treatments for FND could be, for the right patient, really effective. Not everybody. And we have a large randomized trial of psychological therapy for functional seizures, led by Laura Goldstein, called the CODES trial, which received NIHR funding, and that didn't show actually any change in seizure frequency compared to quite expert care, but it did show improvement in a whole range of other domains to do with how much seizures bothered people and quality of life and general outcomes. So I wouldn't wish to overplay and say we've got amazing treatments for FND. I think it's still a very difficult could be a very difficult condition to treat. Not everyone can improve, but relative to other neurological conditions, this is a relatively treatable condition that I would argue that you don't want to miss it. You don't want to miss a condition that might have some treatment attached to it, is how I think we should be sort of pitching it with doctors and patients.
Yeah, absolutely. I'm sure that some patients and viewers to this will be heartened to hear that. And I think you've both touched upon this, so I'm going to put this question to both of you. What advice do you have for medical professionals who may not be very familiar with FND?
If I quickly go first for John, maybe. So I think it's really to get expert help if needed, because there are many people within any organisation that you work with who will be familiar with this and can guide you. But of course, educating yourself and your colleagues afterwards is a sort of critical chain that I think needs to happen. And John has set up the FND Society with Mark Hallett in the US and Alan Carson and a whole, and so really brought the field together. And there's a great load of resources on the FND Society website, a lot of videos that have been, I think, again, there was supposed to be an FND Society meeting, the first big sort of international meeting last year, but COVID obviously put paid to that. But one of the silver linings of COVID is that there's been a lot of online webinars and resources that Alan and others at the FND Society have built up. So that'd be one route. And I don't know if John's got any other thoughts about educating.
Yeah, I think there's a sort of broader issue here to do with, certainly there's a massive issue to do with training. I certainly wasn't taught anything about functional disorders as a medical student, or it didn't appear in my physician training either, even though it's 30% of what I do, 30% of what everyone does. Why is that? There's something really quite wrong, I think, with the way that we are training doctors. And we're saying to them, look, you only to take things seriously if you can see it on a scan or a blood test. And if it's something that you think might be a functional disorder, well, that's probably not your job. It's probably a psychiatrist's job. So I think we've got a real shift in fundamental attitude to make here, to say to doctors, actually, this is your job. These are people who are ill. You've got physical symptoms and you have the skills to be able to diagnose them, signpost to treatment. You might not be the person doing the treatment, but you perhaps should follow them up and see what they think and help and look at comorbidities. And I think my experience is that doctors and health professionals are ready for that. They generally find patients with functional disorders quite frustrating because they're not trained to deal with them. And they often end up blaming the patient for being difficult. Whereas I think actually, if I'm honest, I think nearly all the time, it's the doctors that are difficult because they respond weirdly to the patient. And if they just treat it like any other disorder, everyone's much happier. So I don't know how there's a big problem here because these disorders are very stigmatized. The general public have a great difficulty thinking about a condition where there are physical symptoms in which psychological factors might be relevant, but actually psychological factors are relevant in all conditions. And people with encephalitis get psychiatric symptoms as part of the condition. They get them in response to it. Why are we okay with that, but we're not okay with FND? There's a sort of fundamental stigma attitude thing that needs to shift, I think.
Wise words, bold and wise words. Thank you, John. And you talked a bit about stigma there, Tim. Some patients can be left feeling alienated or even stigmatized, as FND can be explained to them as a psychological reaction to something such as trauma or stress. I can imagine that can be an added difficulty to someone who's already facing the challenges of FND that we've heard about. What's your advice?
Yeah, this is a key and critical issue, really, and it's there's so much misunderstanding around the disorder, and a lot of that's we haven't helped ourselves as professionals because some of the older models were very sort of dogmatic and simplistic, that it was just a stress-related disorder. And of course, stress can precipitate most medical conditions and is involved in the etiology of most medical conditions, but it does seem fairly a bit more marked in FND, but it's definitely anything far from necessary or sufficient. So therefore the whole picture. And many patients don't have any stress in their lives or trauma, and therefore the old model of saying, well, there was this sort of circular argument that psychiatrists particularly and psychologists would get into, which is if you're not reporting or remembering the trauma, then you're either subconsciously repressing it, or even worse still, denying it. So this is the sort of loop that people can get into. But we now know, after having done quite a lot of research and sort of summarizing the research that's known, that quite a lot of people don't have stress. And even if you do have stress, stress is sort of ubiquitous, and proving it's etiologically related to a disorder is very complicated. So I think it's something that needs to be explored, but very carefully, but equally at the right time and the right place. But equally, I think that just the conflation of what the public understanding or lay understanding might be of what a functional disorder is, or it's has psychological mechanisms, it can be very confused with it either being, put on, under your control, something you should just snap out of, or worse still, you're deliberately doing, which is of course nonsense. But it's something that people have a fear of, either themselves or fear of being judged, that's what other people might think is going on. So I think that's a critical issue. That's just a public education understanding. And it's like building up what Jon was saying. There is this sort of public misconception that the illnesses are either physical, or they're put on, they're not real, and they're feigned. And there's of course this other sort of option, which is functional, which is absolutely nothing to do with feigning or being made up, but it's just a different mechanism that can get misconstrued. And the other problem, of course, is just the general globalized stigma around psychology and psychiatry, that somehow it's a less valid reason to be ill, and stigma around seeking help or going to see a psychiatrist or a psychologist, or going into a psychiatric hospital for an outpatient appointment. So those are the things we're all battling with. But I think, again, hopefully just educating the public as well as, and sadly, a lot of clinicians have these sort of prejudices as well. It's not just, and that's just due to lack of education. So we need to educate, get our own house in order in clinical world, but also educate the wider public.
Thanks, Tim. We're going to come back to stigma briefly in a moment, but I was surprised to learn, Jon, that abnormal brain function associated with FND can actually be identified physiologically. Is that correct? And can you tell me a bit more about it?
Yeah, I think it is. And to be honest, it has been a very helpful part of the development of the field in the last 10 or 15 years. We've been able to look inside the brain and see changes in brain function that do appear to be quite specific for FND. And we are helping and also look different to people pretending to have symptoms, which I think is important. And a lot of people sort of expressing surprise at that. Whereas I would say, if you can't move your leg, or you've got a tremor of your hand, what other organ is that going to be coming from? Why wouldn't we see it in the brain? So, and I think it comes back to this sort of dualism that we have in our society, that there's this idea that there's a brain and there's a mind, which is sort of somewhere else. Well, as someone said on Twitter this morning, it's a bit like, the mind arises from the brain in the same way that walking arises from legs. They kind of go together. You can't have one without the other. Obviously, unless your legs don't work. But so yes, we do have studies that show that, I think, that enable us to say, when we say to patients, you've got a disorder where your nervous system's not working, particularly the voluntary, motor and sensory bits. That's a reasonable thing to say. I think it's not working. It's not working in a particular way, which means that when you're trying to do something, it doesn't work. The more you try, the worse it gets. But when you're distracted, the automatic bits are working much better. So that, which is the sort of nature of FND. And I think we are showing changes in the brain, for example, there's a network disorder, but there's a network in the brain that, for example, is to do with agency, which is that part of the brain that tells you that it's you doing something. Those bits of the brain don't look like they're working very well in people with functional movement disorders. So, and that goes along with what the patient's saying. So yes, it looks as if they are shaking their arm in a kind of, you wonder if it could be voluntary, but actually what the patient says is true. It's not, it doesn't feel like them that's doing it. It just happens to be using those voluntary movement pathways in the disorder.
Wow. Okay, well, I said that we'd come back briefly to stigma, and Jon, can you tell me how the functional neurological disorder community is overcoming stigma associated with the condition?
Yeah, well, that's certainly a big job. As Tim mentioned at the beginning, we've got a condition that used to be called hysteria. The words like psychosomatic. I mean, these are the lowest of the low, kind of in terms of stigma. But I think we have seen something really amazing and positive happening in the last 10 years with the involvement of patients. So, because I think there's only so far that health professionals can take this. But what we've seen is the emergence of patient organizations, for example, the FND Hope and FND Action, FND Dimensions, really standing up and saying, look, we know this disorder has this history. But we understand that it does exist, and we're willing to embrace these non-dualistic ways of thinking. So there's been some incredibly brave advocates and leaders amongst patient groups. There's some fantastic advocates on Twitter like FND Portal and FND Recovery that I'd really recommend, who are standing up and saying, yes, I actually do have this condition. I know myself that my leg doesn't work sometimes, and then it does work at other times, but I'm not making this up. This is actually happening to me. And so I'm really excited to see where that takes us. And I think that is a challenge to the people's prejudice and preconceived ideas out there. And there will be a lot of conflict and disruption as we go along. But ultimately, we've got a group of patients explaining to other people what's wrong with them. And I hope with all the research that we're doing, brain research, but also psychological research, and particularly the trials, I think if you show people, here's a condition that we can diagnose with a reasonably high degree of accuracy, and we've got a treatment with a reasonably high evidence base, I think it'd be very hard for people to ignore that and not start to listen. And this is a real condition that they have to grapple with and take seriously.
Yeah. Great. Well, it wouldn't be, we started this podcast series in response to COVID-19. We've now diversified, thankfully, and don't just focus on that. But I have to throw the question to both of you. Have you seen an increase in patients with FND as a result of the COVID-19 pandemic?
Just to go first, John can chip in later, but my thoughts are, it's a bit early days to tell yet. I don't think we've got a huge signal, but as John pointed out earlier on, any physical disease, any neurological disease in particular, is a risk factor for developing functional symptoms, and so therefore on the basis of that we perhaps predict that we'll see an increase. Obviously there is this slightly different, or perhaps increased risk, change with stress, that's a more vulnerable condition to stress than perhaps others. So the sort of stress of the pandemic might potentially create that. But I think clinically we're not seeing a particular signal. There's certainly not been any epidemiological studies I'm aware of that really shown us a strong signal yet. But I've certainly seen a few cases precipitated by COVID personally in the last few months, and I imagine John has. The other thing just to quickly point out is that the COVID vaccines, we've seen a few cases precipitating acute sort of stroke-like presentations or acute seizures, and acute movement disorders as well can happen. So that will happen in a time frame that wouldn't be explainable by another standardized pathological process that we would see resulting from the vaccine constituent. So it's triggered by the vaccine process, not by the actual vaccine constituents itself. And this is something that's well described in Journal FN, but we're seeing that, and we've written up a few cases that are in press at the moment about that. And it's quite an important thing, again, for clinicians to understand, because otherwise people go down the wrong pathway and go down a sort of stroke thrombolysis pathway rather than getting the right help for FND that they need.
Okay, so if I understand you there, you're saying it's not triggered by the vaccine itself, but by the process of going to have the vaccine. Is that correct?
Yes, and it's often the physiological response to having a vaccine, of having pain in the arm or a systemic upset, that is so common. It sort of builds on from that. So it's not the drug causing it by a direct mechanism.
Okay, John.
Yeah, well, I agree. I agree with what Tim said. I think it would be entirely amazing if we weren't seeing patients with who either had COVID or had COVID vaccine that were not developing FND. And I did a seminar with FND Hope at the beginning of the pandemic, just saying that we would see FND triggered by COVID because it's triggered by any illness. And we see, so we've seen it after flu, we've seen it after Epstein-Barr, and that's what you get. Any kind of physical illness will trigger it. I think the studies I'm aware of have definitely not shown an increase in FND, particularly during lockdown. There was one we did with neurosurgical colleagues where a particular type of presentation that was strongly related to a functional disorder did not change in frequency. I think what that showed me was that people were still presenting to hospital with it. What that showed me is how distressed and scary having acute FND is. They were willing to come to hospital in the middle of a lockdown because it was so worrying what was happening to them. So these are not disorders that go away when they're not just sort of worried well people turning up because they can. They're turning up because they're really worried about what's happening to their body. So I think paradoxically, the lockdown actually was interesting because it placed a lot of people who'd not experienced that in a situation that a lot of FND patients find themselves in, which is that they are locked down a lot of the time by their physical disability. Patients with encephalitis too can't leave the house, or if they do leave the house, they're worried about having a seizure or people staring at them. These are things that all people with patients with neurological disability experience. So some of my patients actually paradoxically found a sense of relief actually that everyone was in the same boat as them for a bit of time, and they didn't have this expectation that they had to go out, which can be pretty scary when you've got these conditions. And I think now, as we see these things changing and opening up again, there's a sort of that creates a challenge for some of my patients. And so I'm seeing, perhaps if anything, a bit of an emergence of symptoms as things return to normality.
Wow. Okay, well, we're coming towards the end of the podcast. I've just got a couple more questions for you. You've both touched upon this in different ways, but just so that we kind of have resources all in one place, is there anywhere that people who are listening to this can go for extra information about FND? Where would you both recommend?
Well, as Tim said, we've got. I think I'd recommend the patient-led organisations, FND Hope and FND Action, particularly. If you're in Australia, FND Australia. And there are others. There's for health professionals, there's the FNDsociety.org. I started a website in 2009, mainly out of frustration that there was no material out there for patients. It's called neurosymptoms.org. And so that's a site made by myself and now increasingly my colleagues for hopefully fairly reliable patient information for patients. And we're about to launch a new version next week with an app, so hopefully you'll be able to see that soon too.
Oh wow, exciting. Tim, anything to add there in terms of resources?
No, I think the only thing, just again to I think another great thing is look at some of the online advocates as well. So John mentioned FND Portal, FND Recovery. All the patient organisations and charities have Twitter accounts, and they're often a very good source of information. And some of them particularly do nice threads or explainers about things for patients or the public, which are great.
Great. It's great to hear you both so passionate about, the value of patient organisations, because certainly in the length of time that I've been doing this, that's been a personal challenge. I can remember when I first started working on encephalitis 21 years ago, and I can remember, more than once, but a particular doctor stamping his foot and telling me that we don't get encephalitis in this country. And, so I had many challenges like that. So it's great to hear you both being such wonderful advocates of patient organisations. Well, I'm going to bring the podcast to a close. I've taken up a lot of your time, and I know that you're both very busy. But before we do, is there anything that either of you would like to add or say that you felt we haven't covered today?
I think that's been a brilliant discussion, Ava. I do hope that people listening, particularly if there are patients listening who've had encephalitis or who were misdiagnosed with encephalitis and now have FND, or vice versa, that I hope this really helps them to see that FND is just as valid a diagnosis as encephalitis, just has different mechanisms and different treatments. And I hope they can find health professionals who recognise that as well, because I know I know that is a challenge around the country. But yeah.
Thanks, Jon. Tim, anything to add?
I guess just one final thing is that part of our mission is to not only explain and educate, but also just normalise what is actually a very normal process. We all get functional symptoms to some degree, and you could argue, and I think it's almost certainly true, that that there's a functional component of every symptom, and that's the window in which placebo works. And as we know from trials, that's 20-30% often of any response to any treatment. So therefore, that must be acting on a functional component, and it's whether it's enough to be considered a disorder or needs separate treatment. But that's really just to normalise that this is a normal response that happens in all of us, and it just gets very severe in some unfortunate people. I think that's really what I'd say.
Yeah, thank you. Well, thank you both. We've covered an awful lot, as you say. We're deeply grateful to you for taking the time to chat with me today. For everybody listening, the Encephalitis Society services remain unaffected. So if you need any support or information, our teams remain at your service. Go to encephalitis.info for contact details, or you can chat online with any of our team. And as always, if you can support our work during this very challenging time, please visit encephalitis.info/donate. Most of all, keep washing your hands, stay safe, and get vaccinated. Thank you.
Thanks.
Thanks. Bye.